Good morning, good afternoon, good evening, everyone. You're welcome to today's episode of Public Health in Real Life. The World Health Organization states that approximately 5% of the world's population carries trait genes for hemoglobin disorders, mainly sickle cell disease and thalassemia. Hemoglobin disorders are genetic blood diseases due to inheritance of mutant hemoglobin genes from both generally healthy parents. Over 300,000 babies with severe hemoglobin disorders are born each year, most of them in the Mediterranean and sub-Saharan Africa. The health burden of these hemoglobin disorders can be effectively reduced through management and prevention of programs. Today is World Sickle Cell Disease, and on today's episode of Public Health in Real Life, we have an amazing panel of sickle cell advocates, warriors, and researchers who will be shedding the light on sickle cell disease as we celebrate World Sickle Cell Disease. First of all, I would like to highlight my co-moderator, Marius. Welcome to today's episode. I think we have a problem with Marius's audio.
Hello, Maimuna. Hi, everybody. Thank you so much. I'm glad to co-host this session today. I am Mariso. I am a PhD candidate enrolled at the Catholic University of Central Africa in Yaoundé, Cameroon. And I'm very excited about this session today. Over. Thank you.
Thank you, Marius. Our first panelist is Funke Akiyode. Funke Akiyode is the Executive Director of Shout Global Health and a Director of tutorsareus.org. Prior to this, she has worked at several government and non-profit organizations. She holds degrees in accounting, biological sciences, advanced degrees in international health, health service administration, and an MBA. She's presently a PhD candidate in health economics and health research at the University of Texas Health Science Center. She has presented many papers nationally and internationally on many health issues, including gender, women's rights, and of course, sickle cell disease and global health. She has been featured in several magazines and co-authored books on health issues. Funke is a person living with sickle cell disease, had her first pain crisis at the age of 5, and understands many challenges that come with being a warrior. You're welcome to today's episode, Funke.
Thank you so much, Melinda. Thank you, everyone, for having me.
Our second presenter today is Dr. David Owoeye. David is a sickle cell warrior and advocate who uses his sickle cell experience of sickle cell crisis, complication, and discrimination and abuse to create awareness about sickle cell disorder among the public, educate and inspire other sickle cell warriors to rise above limits, improve sickle cell care, and to encourage more research in sickle cell disorders. He is a medical doctor specialized in infection prevention and control, and currently he is working on regional surveillance coordination at the General Directorate of Infection Prevention and Control, JESN, Ministry of Health, Saudi Arabia. Welcome, Dr. David.
Thank you very much. Welcome. Thank you.
And our last panelist for today is Dr. Melinda Rushing. who is an applied data scientist with a research focus on sickle cell disease and the application of data science methods to health data. Dr. Rushing graduated with a Bachelor of Psychology in 2010, a Master of Social Work in 2012, and recently a Doctor of Public Health in 2021. Dr. Rushing was recruited to join the University of Michigan Susan B. Meister Child Health Evaluation and Research Team as a Data Analyst Fellow for the CDC's Sickle Cell Data Collection Program this fall. Dr. Rushing has 9 years of social work experience, where she spent the last 5 years working with sickle cell patients treated at the Texas Children's Hospital Sickle Cell Clinic. Dr. Rushing is very passionate about using data to improve the way sickle cell patients are medically and socially treated across the age spectrum, locally, nationally, and globally. You're welcome to today's episode, Dr. Rushing.
Thank you so much. I'm honored to be here.
So straight to the business of the day. We've talked about sickle cell disease and the burden. Dr. David, as a sickle cell disease warrior and also a medical practitioner, how would you describe sickle cell disease to the layperson? Your audio, Dr. Owoeye.
Oh, okay. Sorry. Sickle cell disease, like disease describes itself. Disease is a condition that makes you easy. So I could, from experience, say sickle cell is a disease that makes you uneasy. Sickle cell disease is like a chronic disease, an inheritable blood disorder that have like a pan-systemic, and I want to use a better word for the layman. It affects all systems, organs, or tissues in the body, basically because the problem is with blood. Every cell, every tissue, every organ, every system in the body needs blood. So as long as blood flow to those regions are affected, sickle cell can affect it. Now, however, sickle cell has different manifestations. Sickle cell have triggers in terms of things that causes crisis. There are sickle cell crises, there are sickle cell complications, and then there are also mental sides of sickle cell or mental complications of sickle cell. There are cases of conditions in sickle cell disorder that, medically speaking, we have limited information, which we are still trying to discover, and from experience of sickle cell warriors sharing it with others, we're able to understand it better. So there is so much of sickle cell disorder, which I'm going to use to describe it, so much of sickle cell disorder. What we know about sickle cell disorder is what medical research have told us, and the little sickle cell warriors have informed us. And that is why it's important sickle cell warriors should speak about it so that people can have a proper perspective about what sickle cell disorder is all about.
Thank you so much for that introduction, Dr. David. So Dr. Rushing, a quick question for you as a data scientist. What are the predisposing factors to sickle cell disease, and then what populations are most affected?
I'm sorry, you said what was the first part of the question?
Like predisposing factors, like socioeconomic factors, and then also the populations that are most affected.
Okay, well, I'll start with the populations that are most affected, which will be people of color pretty much. And so those that are African descent, as well as those of Mediterranean, Indian, and Latin descent are the primary populations that we see. Over in North America, I'll say the US, you're mainly going to see people of African descent and Latin descent. But over in India, there's a huge sickle cell population as well. Because it's a genetic disorder, there really isn't like social factors that are like kind of that cause like or are predisposed the patients to having the disease. It falls back on genetically this genetic mutation being present, and then we're seeing that it's more common in these populations. They researched, I forget what year, how it's been several years or maybe a decade or so ago, that they did find a link between areas or regions where there were high malaria incidents having this sickle cell mutation. The sickle cell trait, because what they found was that people that had the sickle cell trait were less likely to die from malaria because the malaria was not able, like the virus was not able to survive in those that had that trait. But then because of like, reproduction and just breeding, then we see that sickle cell trait then became sickle cell disease. So that's more of like the issue of like regions that had the high malaria incidence. We've seen that those more people there that survived had the trait, and then after reproduction, you see the trait. It was recessive, but combining with another parent that had the recessive trait, then developing the disease. And we've also found that there's different traits like C hemoglobin, and then I think it's beta thalassemia. I can't remember if it's major or minor. To where combined with the sickle cell trait, you'll also have sickle cell disease.
Thank you for enlightening us on just the genetic factors and then some of those intersectionalities with malaria and then sickle cell disease. So Funke, you have an interesting history where you were born and bred in Nigeria and received treatment for sickle cell disease. You said your first pain crisis was at the age of 5, but now you currently live and work in the US and have also received treatment. Can you shed more light on your treatment experiences in a high-income country versus a low and middle-income country?
Thank you for the question. And I'm going to actually start my the answer to these questions using an analogy. I'm going to use the then and the now. So it's going to be an analogy of then and now. My experience is about 20 years ago. I'm going to look at my experiences, other people's experiences then and now. And I'm going to start with the issue of pain crisis. We all know the major thing in sickle cell disease is pain crisis. And pain crisis, as we all know, is a gateway to other complications in sickle cell disease. It's actually the more pain crisis you have, the more it feels that there's a high relationship with mortality, complications, morbidity when we talk about the more pain crisis someone has. So my analogy is going to be from treatment of pain crisis 20-something years ago, and treatment of pain crisis in low-income countries 20-something years ago, treatment of pain crisis now, and also treatment of pain crisis in high-income countries 20-something years ago, and treatment of pain crisis in high-income countries now. So in the low-income countries, when 20-something years ago, treatment of pain crisis was they used basically like Anagene, Novocaine. So there were no opioids were not used. I did not remember getting any opioids for my pain crisis as a sickle cell patient. So what it basically meant was that people were dying of preventable pain. So they're just going to have pain and have pain and have pain and die. So now, at that time, in the high-income countries, opiates were already in use. And even then, in the low-income countries, that opiates were not used then, people didn't even have access to the Novocaine, the Anagene, because of the high out-of-pocket costs. Now, moving from there to, I'm going to look at now. Okay. So now I know that people can get access to opioids in low-income countries, but come to think of it, how can they afford it? If you don't have money, there's no way you can get it. And if you don't get the opioids and to treat the pain crisis, someone can die like that of pain. That's just preventable pain. And now, in high-income countries, opioids is being used. But the problem that people have now in the high-income countries is the problem of stigma. When they talk about the opioid crisis, the first thing that comes to mind, a person who has sickle cell disease is basically looks younger than their age. They are minority. So when they get to the hospital, the first thing they're going to ask you is, how many pain medications do you have? You have oxycodone. You have Percocet. What are you doing here? So people don't understand. Physicians and healthcare professionals don't understand that sickle cell pain is different. It's like you're just drug seeking. You look good. Why are you here? You don't look like you're in pain. So those are the kind of challenges that are being faced in the high-income countries now. They're talking about opioid crisis because they have a lot of opioids. The World Health Organization says that opioid is an essential medication, but it's not available in some countries. And because it's not available in some countries, and low-income countries now is not that available, then people are dying of preventable pain. But here in the high-income countries, people are faced with stigma. And because of stigma, they don't want to go to the hospital. or they look for a hospital that is really far away to go to. So those are some of the challenges of then and now. Another then and now thing I'm going to also look at is the issue of hydroxyurea. 20-something years ago, hydroxyurea is a medication that is taken that stimulates the production of fetal hemoglobin. And when it stimulates the production of fetal hemoglobin, it reduces the number of pains that you have. Then there was no, I know hydroxyurea is probably, it's not that new, but it's like 25, 30 years ago. Then 20-something years ago in low-income countries, there was no hydroxyurea. Here, they were using hydroxyurea at that time. So people still had a lot of pains, and when you have a lot of pain, more morbidity, more complication. So when you come here, then you have access to the hydroxyurea. So the number of pain crisis reduces. So that's another thing between then and now. So now there's hydroxyurea in low-income countries, but how many people can afford it? So we go back to the issue of access. But as we know, hydroxyurea doesn't work for a lot of people. So within the last 10 years, there are the new medication, the Advocacy, L-glutamate, voxelotor, oxabride. There are so many of that are coming in the last 10 years, 5 years. But I'm sure there is no Advocacy right now. Advocacy and voxelotor, oxabride, they came like last year or last 2 years. Right now, there is no, people in the low-income countries, they don't have access to those medications right now. And even if they do, can they afford it? Because they're pretty expensive.
Well, that's really enlightening, Funke. And speaking of experiences, David, I actually want to ask you about your experiences from the medical perspective and then also from the patient perspective, having to deal with sickle cell disease. How has your treatment experience been like? And then how have you also been able to provide treatment? And, like they say, health is beyond just physical health. It's also mental and psychological. So how is mental health affected with sickle cell?
Thank you, Memunat. Sickle cell directly has effect on your mental health, especially when you're in pain crisis. At times, the pain crisis could be so bad that you have feeling of guilt. Okay, let me try and say it like this. Some weeks back, I just resumed work. I went to work after a weekend, and I was feeling gloomy. And my colleague, a nurse of almost 20 years experience, asked me, why am I looking gloomy? And I told him I had pain crisis within the weekend. And he said, no, it can't be just because of the pain crisis that I'm still looking. I had to tell him that, see, is it that you don't know that sickle cell has mental consequences to the crisis that comes? And so at times there's this feeling of guilt that, oh, is it that I did something wrong? At times there's this feeling of hopelessness. I've tried everything they said I should try. Now there are the do's and don'ts of sickle cell crisis. They tell you prevent dehydration, prevent exposures to extremes of temperature, prevent infection, prevent stress. But at times as a sickle cell warrior, after abiding with all these do's and don'ts, the crisis still comes, the pain crisis. And some of those pain crises are so devastating. They could take a longer period. They could be very severe. So you are like, what else can I do? There's this feeling of hopelessness. I'm a medical doctor. I've seen patients with diabetes, and then they're having diabetic crisis, and place them on insulin and other medications, and there's like a miracle. But at times it doesn't work like that for sickle cell. You place them on. I've been in a crisis whereby I had to use petidine, 100 milligram, 8 hourly for 3 days, and the crisis is not stopped. So now, as a doctor, Dr. Memunat, petidine is like one of the most potent pain drug in the world. After petidine, what else do you want to do? So that kind of condition puts you in like hopelessness. What else will I do? In terms of preventive management, I've done everything I could do. So all those can at times make you depressed. Now, one of the problem or one of the triggers of a crisis is mental stress. As I was growing up, I got to realize that, whenever you're having a premonition of a crisis, or whenever you're in a crisis, you need to be able to guide your mind and prevent your sanity. So whatever I know could stress me mentally, I try everything to ensure I prevent it and I manage it. Because once the crisis starts, if I am still stressed mentally, the crisis could become severe. The crisis can stay longer. So there are other aspects to mental problem. Even when you have chronic fatigue syndrome, The chronic fatigue at times, when I had to do a research on what it is in sickle cell disorder, I saw that medical literature compared it with what people who have cancer or HIV have. And see, for me, while I was in medical school, I was growing up, working up, I never experienced chronic fatigue because I was this multi-talented people. I was engaged in a lot of things, multitasked. As I was engaged in business in medical school, I was also engaged in the Christian fellowship, and I was getting awards, and my medical career was not suffering. So when I was closing up to the age of 40, I started having this chronic fatigue, and I couldn't understand what was going on. I thought maybe I was just getting lazy and procrastinating. At times, I itemized, I want to do these 4 or 5 things, and after doing one, I feel so tired. It's as if the next step I'm going to take, I'm going to faint. And I still struggle to do something, and if I still struggle with it, I have a pain crisis. So I was confused for almost 3 years what is going on. So that gave me a kind of anxiety. Anxiety is another mental stressor, it's another mental dimension to sickle cell disorder. And then when I got in touch with another sickle cell warrior older than me, and she explained to me that what I'm having is chronic fatigue, that she also has it. That's when I was able to understand that, oh, as a sickle cell warrior, chronic fatigue also have problem to it. Now, other aspect of sickle cell disorder, there is pica. And pica is eating of endogenous substances. Now, one of the things I observed when I was having problem with pica, then I was eating sand. The addiction with pica is like the urge to eat this inordinate object. Even when I'm filled and I've eaten a meal I like so much and my stomach is distended that I'm already full, I know I'm full. I'm not satisfied until I get to eat sand. And so I was able to correlate that, when a sickle cell warrior gets addicted to an opioid, whenever you are in a crisis, no matter what anybody says, until you get that opioid, you're not going to stop craving for it, and the pain is not going to stop. That addiction was like the same urge I felt when I was having pica. So there are a lot of mental consequence or mental implication or mental dimension to sickle cell disorder, which medical science has not been able to help us identify properly. There are periods of mood swings that you have as sickle cell disorder. At times you feel like you can conquer the whole world, you can do anything, and at times you feel like you feel so hopeless, you don't want to do anything, or you just feel like the world should come to an end, or you just feel like you don't want to live again. And I've had cases of sickle cell warriors getting into suicidal attempts or depression, chronic depression. There are cases of panic disorders. So there are a lot of problems that we've not been able to unearth. And one of the issues I would say is it depends on how sickle cell warriors are able to speak out about it. And then it is important also qualitative research is put into sickle cell disorder so that they could hear sickle cell warriors speak out about how they feel, how they experience some of those things. Now, in terms of caregivers, as a sickle cell warrior, and then as a medical doctor, at times as a medical doctor, if you compare countries with high income with countries with low income, in medical school, we are taught common things occur commonly. In countries with low income, you see cases of sickle cell warriors come to the hospital for a sickle cell crisis. So you are used to them. You are used to the fact that when they come to the hospital, you don't start them with paracetamol, Panadol, or any of those lower drugs because they've used these things at home. They've used NSAID at home and did not work. So you can start them with something more potent. But for high-income countries, where you don't see a lot of sickle cell warriors coming to the hospital frequently, like low-income countries, you find a problem where you are talking to the healthcare worker that you're having, the caregiver that you're having crisis, and the person is starting you on Adol, paracetamol infusion, and you're like, no, it's not going to work because you tried it at home. And he or she is telling you I have to follow the protocol because they don't understand it. And then they've not seen those things commonly. So there is this issue of sickle cell abuse whereby the sickle cell warriors feel they are not given the appropriate treatment. Or you give them the normal potent medication, you should give them pain reliever, and they're telling you they're having crisis again, and the pain is not stopping. And then the doctor is like, you're just lying, or you're not being serious. But low-income countries, you see a lot of cases like this that makes you understand that, there are evidence that this is not lying. The person is seriously having this. You've put a patient on tramadol injection, and it doesn't work after 1 hour, and you place the patient on pentazocine, and it doesn't work after 2 hours, and you place the patient on petidine. And you've seen this commonly. So when the patient comes to the hospital again as a caregiver, and the patient is telling you, I'm having pain, you won't start the patient on paracetamol or NSAID because he has tried that at home. And then you can now start the patient on other potent medications like opioids, because at that point that patient is seeking care, he or she has tried every other thing that could prevent the pain, and it's no longer working, and that's why they come to the hospital. So there is this dichotomy between caregivers in high-income countries and caregivers in low-income countries, basically because common things occur commonly. In high-income countries, frequency of patients with sickle cell disorder coming to the hospital is low compared to people in low-income countries, whereby you see people with sickle cell disorder coming frequently to the hospital either triggered because of malaria infection or other form of infection. How many cases of infection do you have? So much like that in high-income countries compared to low-income countries. And infection is a trigger of sickle cell crisis. So infection is there to trigger crisis, physical state is there to trigger crisis, mental stress is there to trigger crisis, dehydration is there to trigger crisis, extremes of temperature are there to trigger crisis. So all of the triggers of crisis occur frequently like that in low-income countries. And then you see the patients coming frequently to the hospital. So you are used to them. You are used to the things you're supposed to use to manage them properly. And then between a day or two, they're out of the hospital. And you can be rest assured that they're not going to come back again with crisis until after they are clinic. But aside that, there are instances at times when even after you've done everything, nothing else works. And so I think that's where medical research will have to help us be able to unpack what are those other aspects of sickle cell disorder that we don't know about, which I think we should know about to help us improve care in sickle cell disorder.
Thank you, Dr. David. Thank you for elaborating from a personal perspective and making a difference between the developed and the developing world. So now to Dr. Melinda. So I want to ask, how has sickle cell disease research evolved within the past decades, especially current innovation in sickle cell disease diagnosis and treatment?
Yeah, that's a really good question. And I think that it kind of goes or shows why the experiences that Dr. David and Funke described are still happening today, even though sickle cell has been around for decades, centuries. And like this question kind of points to the importance of research. And so in the last 10 years, honestly, sickle cell research has been very slow. And I feel like now it's starting to pick up a lot because although the opioid crisis was a negative thing, but it also shined light on an issue so that we can correct the stigma that's associated with sickle cell patients and also create new treatments to prevent pain crisis and organ damage or organ failure and all these other things that sickle cell patients have to endure, but that have been overlooked for so long. So in the last 10 years, and really, like, what I want to say about data is that money really drives what we focus on. And if we look, we see there's so much that we've learned about cancer or diabetes, and there's multiple drugs and clinical trials and things like that are going on. And it's because people that have the money or organizations that have money or large sums of money have interest in those diseases. And so they're driving research so that we're able to improve how patients are cared for. Now with sickle cell, money is starting to come into the field so that research can be dedicated to understanding sickle cell and improving treatments. In the last 10 years, for the longest, I think hydroxyurea wasn't even approved for. I think it was the last. I think 2014 was when it was approved for children, I believe. Oh, actually, I think maybe it was adults, and then a couple of years ago, it was approved for children in the U.S. Like the FDA approved it, and that's really. It's sad because hydroxyurea has been used for so long, but it wasn't officially set as okay, this drug can be used to treat sickle cell, even though it was found repeatedly to be successful in improving outcomes. But now in the last maybe 5 years or so, there's been a number of new medications that have come around to treat sickle cell, and really the tangible symptom that we see is a pain crisis. But in order to stop pain, you need opioids. You can either prevent it or you're going to need to treat it in the crisis. And because of the opioid crisis, it made things it made things harder for sickle cell patients to seek out treatment and develop or at least higher income countries, because when you take opioids throughout your life, your tolerance for it is going to increase. And so your starting dose as an adult is going to be higher than it was for the average adult patient that's coming in experiencing pain, because it's chronic pain. And so but also what we teach sickle cell patients is that you need to be on top of your, or you need to be like kind of, you need to guide your care. You need to understand what you need. You need to be able to speak up and explain with the doctors, because it's considered a rare disease in these higher income countries. And so you have to basically kind of help the provider treat you by explaining what you need. And for other diseases, this will work. But because of the use of opioids, it makes it harder for sickle cell patients. And so that means that we need more medications and more treatments that can prevent patients from even having a pain crisis. Because if we can just kind of stop that before it even gets there, we would see, I think we would see the stigma of sickle cell patients change. So these new medications are like pivotal in like changing the trajectory of how sickle cell patients are treated. And I think across the world, really. But still, there's more that we can do. And there, as we kind of talked about a little bit earlier, that there's a huge psychological or psychosocial component to treating sickle cell or experiencing sickle cell that we do not understand. It was mentioned in my introduction that I'm joining the University of Michigan to kind of start looking at these psychological and psychosocial factors that are impacting sickle cell care, because of the people group that it does affect. A lot of times we're seeing high levels of poverty, and poverty really is a huge factor when it comes to accessing care. In the U.S., we do have Medicaid, but Medicaid, the policies around Medicaid are really state by state. So meaning if you're in one state, it may be easy to get it, but in another state is more challenging. And so that makes care it makes accessing care even more complicated, because you need insurance in order to be able to get your medications, go to your appointments, be able to be admitted when you need to. And so poverty is something that we really need to understand more of the factor that it plays, so that we can impact our policies in the U.S. and in these other higher income countries, so that patients that are sickle cell patients that are there are able to get the care that they need, because they take away that burden. Another issue that we see is that in lower income countries, as Funke had mentioned, like they may not even have the medication in the first place. And so the more treatments there are, the less one medication kind of control or monopolize the industry. And so we need to have multiple options, so that depending on income or depending on location, the patients are able to afford them and access them. So that's another piece. On one side is like developing the medications that are needed, increasing that. On the other side is understanding how these different social factors impact and create barriers to sickle cell patients getting care. And so another issue that we're seeing is we need to see what the connection between mental health challenges and experiencing pain, which we know that is there. We've seen there's a link, but we don't really know much of how can we support or improve mental health. And then as mental health is improved, how much improvement do we see in sickle cell complications that are experienced? Because sickle cell it affects the person holistically. So it's just you can't focus on the physical. You have to focus on the person as a whole. And if their mental health is being affected by managing or dealing with the disease, then we need to understand how much weight does that have when it comes to treating the patient. So right now, what we're looking to now is that there is more, in the U.S., we do have some federal funding that recently came out that is expanding a sickle cell surveillance program, the one that I'm going to be working with, which is great because now we're going to have multiple states, and eventually the goal is to have it nationally, so that all the states are able to work together in looking at these different factors and understanding how poverty or access or like medication utilization and things like that, how they are affecting the outcomes of sickle cell patients, which is amazing because 5 years ago when I started my PhD program, none of this was there. And I really wasn't sure what would be there. I'm sorry, 4 years ago, I really wasn't sure what would be there when I graduated because I wanted to continue in this field. But now there's a lot more interest and a lot more funding that's being poured into it. So more fields of expertise are getting involved. I think it was heavily the focused in the medical field for so long, which is important because doctors and nurse practitioners and physician assistants and these different providers, they're the ones that directly treat the patients. But we also need the people that are on the policy side in nations around the world. We need people that are involved in global health or are leading the whole global health industry, people like myself in the data field, in the data industry, to have interest in this topic, because it really is going to take all these systems coming together and understanding this disease and creating systems or a system that will make access to care better. I also improve the care that we provide and really debunk the stigma that's associated with the sickle cell patient as being drug seeking or whatever, which there's also a huge racial component behind that as well. So I mean, like it's a challenging disease to tackle, but it's not impossible. And in these last couple of years, we're seeing that more people that are in these higher positions are becoming more interested in it. And we're getting more opportunities. Oh, I'm sorry. Another thing that is on the horizon is genetic therapy, because originally the only cure for sickle cell was to go through to get a bone marrow transplant. But a lot of people were not able to even access that because of cost, as well as because of needing, seeing better outcomes with relatives that, getting the bone marrow donation from relatives or matching it that way. And so it was a lot. Although this was a potential and it was found to be effective, there a lot of people, it just wasn't available to them. But now that we have genetic therapy coming down, and we're seeing this amazing things on the side of genetics with being able to erase the sickle trait. So, and then now the body's able to basically reset itself in a way. It's I'm layman's term, being able to reset itself, which is amazing because it takes out a lot of the burden of going through a bone marrow transplant. But on the other hand, this is a very expensive treatment. And so although it is something that we're discovering, many won't even be able to access it. So there's a lot more that we need to do as we understand the disease more and more. Genetic diseases are very challenging to work with or to be able to treat and cure, but it doesn't mean that it's impossible. And we're making I shouldn't say we're making a lot. Things are starting to change, and I believe it's only going to get better and better because we have so many other industries that are now invested in improving outcomes for sickle cell patients.
Thank you, Dr. Rushing. And I imagine you're talking about that trial that has been conducted in mice on genetics. I think it's by the NIH. I saw an article on that recently and how that could be the future of sickle cell therapy.
Yeah. They've done a couple of trials in patients as well. It's only a handful of them, but I know at my current hospital, they are a part of a national trial, random control trial, to where they are doing this procedure within patients.
No, that's really great to know. Funke, you had mentioned, the barriers to seeking care from a, low and middle income country versus a high income country. I want you to elaborate more on those barriers that patients encounter when they are seeking care, when they are reaching care, and then when they are actually receiving care.
Thank you so much. I'm going to actually look at a couple of barriers that patients my face, like let's say in the low-income countries, for example, I know that the issue with low-income countries is the high out-of-pocket costs. High out-of-pocket cost facility. I remember that someone was asking me, one of the doctors was asking me, because here, when you get sick, the first thing that happens is when the 911 comes, the ambulance comes, they put you in the ambulance, and then they give you oxygen. That's the first thing, oxygen therapy. So one day when I got to the hospital, I don't know, I was talking to one of the doctors, and one of the doctors was like, okay, now remind me what happened in I'm not gonna in the low income countries. Do you get oxygen? And I'm like, when you fall into that crisis, is that the first thing they give you? I was like, no. I don't know what happens now, but then no. Because oxygen therapy was not, there were not a lot of oxygen supply that they could just give everybody, a lot of people oxygen when they come in like that. So I said no. So that's actually one of the major facilities, facilities. So I would say that all countries are actually not designed for, a lot of countries are not, a lot of health systems are not designed for high utilizers. Sickle cell patients are high utilizers. Even in United States, for example, before the passage of Affordable Care Act, sickle cell disease was counted as a pre-existing condition, and that means you can't get private insurance. So what it means is that you have to be either super poor, and I'm not saying super poor, you have to be low income. So you have to make yourself low income to be able to afford Medicaid. So, and if you are not high income, you can't afford the private insurance. So, and let's look at a person with sickle cell disease. You don't know when you're going to fall sick. It's unpredictable. So I call sickle cell patients people that start over, masters and start overs, because they build something and then one day it falls off and then they start over again. So with that, it's going to be really challenging keeping a full-time job that will give you that insurance. So you're basically in the middle and you are like no insurance. So think about a sickle cell patient with no insurance. So it's either you say, okay, you know what, I'm just going to leave all the jobs and go straight for Medicaid. Because if you're in the middle, but thank God for ACA, Affordable Care Act, which actually reduced that. So actually that's actually gave a lot of access to a lot of sickle cell patients. So basically in the low income countries, we're talking about a huge out-of-pocket cost that comes from utilization, which a lot of people cannot afford, which will reduce the access. So in high income countries, we're talking about other social economic stuff that comes with it. And even if you have a private insurance, look at the huge amounts of co-pays that comes with the private insurance. Huge. I'm telling you, it's huge, because I have a private insurance and I'm looking at my bills. I'm like, so when did I get this? Oh, this is $600. Oh, this is, and I'm like, oh my gosh, it's huge amount of out-of-pocket cost too, in terms of co-payments, in terms of the deductible. Even if you have a high deductible health insurance, it's a huge amount of bills. And in high income countries too, that's a humongous actually amount of bills that comes. So those are challenges that might come to sickle cell patients and sickle cell warriors in terms of seeking healthcare. And this can actually affects the health of a lot of people.
That's really great to hear, Funke. Thank you for that. David, over to you about from a provider perspective. Studies have shown that you either don't have enough people specializing in sickle cell disease treatment, or there isn't adequate, funding to support training and research. So from your experience working in different settings, what is the state of providers who are able to treat sickle cell effectively? Oh, I think we lost David. So I would ask that question to you, Dr. Rushing, because you spoke about sickle cell care being beyond just the medical, the doctors, the nurses, and the, physician assistants, physiotherapists, and all of that. So what are opportunities for people interested in managing sickle cell disease?
Yeah, there are a few, or I guess multiple opportunities, because there's different like postdoc or fellowships that people can apply for and participate in. For those that are in the medical field, those are in the psychology field, as well as those that are in the public health field. And so with these, like on the medical field, I know, and I'm just speaking about in the United States, there's one, since there's a huge fellowship that doctors can, or medical students can go to, and in Cincinnati, Ohio. And actually Cincinnati, Ohio is kind of like leading the charge when it comes to sickle cell care. And so they're producing a lot of providers that specialize in sickle cell care, or they're training them. There's also another one here in Texas. It's up under the hematology fellowship, or hematology oncology fellowship. But we have a large sickle cell pediatric clinic down here in Houston, and people are able to, or doctors are able to go through that training. As from like in the public health field, recently, because the federal government, the CDC, has expanded their sickle cell data collection program, there's I think there's 2 or 3 like public health fellowships or postdocs that trainees can go into, and then also at Children's National, which I think may be in Boston. There's another fellowship for psychology or psychologists that they can in treating sickle cell patients. So there isn't like a whole lot of opportunities, and you definitely, anybody interested is going to have to seek them out. But there are a few for those 3 industries that I'm familiar with. I think there will probably be more as more people that move up to these higher positions. Oh, I think Dr. David's back. He may be able to speak more on the international side.
Yeah, we actually, Dr. David, we lost you for a bit. So the question was, how do you encourage more providers? Because studies have just shown that there is inadequate number of providers specializing in sickle cell disease or even understanding the condition as a whole. So how do you encourage more providers, training, education, and expertise in sickle cell disease? David, can you hear us? Seems to be having some problem with his connection. If you can hear us, we'll get back to you. So whilst we wait for David to connect, we want to talk about the issue of advocacy. Starting with you, Dr. Rushing, today happens to be Juneteenth. And we all know, well, we probably don't all know the history behind, because that's a US specific holiday. But then it touches on, it's something that has to do with the African American population. And as you had said previously, that sickle cell disease actually affects and is a burden to the people of African descent more. So with that increased awareness on Juneteenth and what the government has done to just, allow for the recognition of that day, how can the government extend support and policies that would then support sickle cell disease?
Yeah, it's an exciting time, and it's a huge deal that our government is recognizing Juneteenth, because the history of slavery really has stained our country, but it's also the ramifications of that evil is still very much so present in our society. And so, just to really quick summarize what Juneteenth is, it was when the last African American slave, I would say African slaves were freed, or were told that they were free, because I believe it was maybe a year when actually the Emancipation Proclamation was signed. But down here in Texas, in Galveston, was when the final a message came to let like the Texan slaves know that they were actually free. And so we celebrate that here, but for a long time it has been like a holiday that's been on place like in the background, and it wasn't really valued, because I feel like a issue within the U.S. is that slavery really hasn't been addressed, and the impact of slavery on African Americans has not really been reconciled or acknowledged for since it happened. So now with World Sickle Cell Day also falling on the same holiday, it's within our government actually recognizing that holiday. What the next step needs to be is to start looking in and putting efforts, like financial and just manpower, into addressing these different social as well as medical issues that largely affect the Black population here. So sickle cell is one of them, as well as diabetes. Really, if you look at just like mortality rates, African Americans almost lead in all of them. And there's a huge social component to that, and why we see these outcomes the way that they are. Like still, African Americans lead in maternal mortality. After we've made so many advances to improve labor and delivery, but still, like the threat of African American women dying during birth is still very much so present. And then when you add on a disease like sickle cell, like it's like the risk is so high, and you're already coming in kind of in a disadvantaged position, because again, people when we report different complications such as like pain, or we're not feeling well or whatever, they're dismissed during the procedures, and which is what leads to a lot of to mortality. The same thing with sickle cell. Like you're dismissed when you're saying like, okay, well, my pain is still there, or breakthrough pain, or like the level that the medication that is not effective. So what our government needs to do with this great acknowledging this holiday, or acknowledging our like official freedom, but there's still areas to where we're not free. And health is a big place, a big issue that we have. And so, yeah, the money and time and opportunities and incentives need to be developed so that professionals are drawn to this industry to understand. And it's not just, although sickle cell largely impacts people of color, and is not, it cannot only be people of color that put energy toward eradicating this disease and improving outcomes and improving how patients are cared. We as a country have to all come together and do this, because although the disease is considered rare, it is major within the Black community. And one thing that I did when you were talking about how providers, it's been found that providers that are more knowledgeable of sickle cell it's just better outcomes associated with those patients. That was actually part of my dissertation, where I found that when I looked at hematologists, primary care providers, but providers, whether hematologists or primary care, that cared for 20 or more sickle cell patients in the last year, those knowledgeable providers had patients with the lowest emergency department visit and inpatient stays. So training providers is going to be huge, because the disease is complicated. And although you may have book knowledge, you have to have the actual like in-field experience. So we definitely need more training programs. And another issue is that on the reimbursement rate here, meaning it's kind of how much doctors and hospitals and clinics are paid based off of the treatment that they provide. Although a provider that's a hematologist, they're also an oncologist, like they're trained the same, you will get reimbursed at a higher rate for treating an oncology patient or cancer patient rather than a hematology patient. But a lot of the hematology illnesses are genetic, such as sickle cell, and it's extremely complicated to manage it because we don't know enough. So we need to improve the reimbursement rate for providers that treat sickle cell patients, because then, just like when medical students are going through their studies and they decide, okay, oncology, like money plays a huge role in what field people go into. And if you're going to get reimbursed at a higher rate or paid more as an oncologist, of course you're going to look into that field, unless you're just passionate about doing something else. So we need to put that money behind it, and we need to improve how hematologists are paid when they manage a disease like sickle cell, because again, it's very complicated. It's very like time consuming. It pulls a lot of energy, a lot of problem solving, and expertise, and they need to be adequately paid for that.
Thank you, Dr. Rushing. And you had definitely shed a light on the reimbursement aspect of it, because I think a lot of times people just talk about training and equipment and supplies and forget that reimbursement plays a huge part to motivating and just inspiring providers to pursue a certain career path. So Funke, on that topic of advocacy, what have been your successes, challenges, and lessons learned in sickle cell advocacy?
I'm going to say, actually, I'm going to talk generally actually about the success of groups on sickle cell advocacy. I know that in the last couple of years, there has been light that has been shed on like how there's not a lot of money in research as compared to genetic conditions like cystic fibrosis, So, and that actually in the last decade had made some medications that are actually solely for sickle cell disease. Before then, there were medications that were solely for sickle cell disease. Hydroxyurea was an accident, it was for leukemia, and all of a sudden, it works for sickle cell disease. So that shows that there wasn't actually something that they weren't looking at a medication solely for sickle cell disease. That was an accident. So in the last decade, there have been efforts that people are now looking at. Let's look at medication that's solely for sickle cell disease, and that had happened in a couple of years. And the fact actually that, and we're talking about a priority list of of people to put on the COVID-19 vaccine. I was glad that this year sickle cell disease was actually was one of the priority lists. Which shows that there's more awareness. People are success. There's little successes that we need to actually agree on. And like Dr. Melinda was saying, Dr. Rushing was saying that there's a lot, in the last couple of years in funding, people are beginning to realize that sickle cell disease has been neglected. And I know we still have a whole lot more to do. And yeah, basically, those are kind of the successes that we can actually say yes to.
And I think just elaborating on that, what have been some of your own personal efforts at advocacy for sickle cell disease, Funke?
Yes, actually, I have a nonprofit that we talk about sickle cell. Sickle cell is one of the things we talk about, even though we talk about all other diseases, majorly some neglected diseases. The nonprofit actually, one of the things that we do is, because we know that in low-income countries, Melinda also know about this nonprofit, and everyone here, in low-income countries, people don't have access. It's like I was saying, it's huge out-of-pocket payments. So we kind of like created a fund that we could actually give to people who need hydroxyurea. Those are some of the things that we're working on. If you go to shoutglobalhealth.org, you're going to actually see some of the stuff that we do on global health and health issues, and on sickle cell disease, like providing medications for sickle cell disease patients, especially in low-income countries.
Thank you for highlighting Shout Global Health, Funke, and we'll be sharing the link and other resources at the end of this. So Dr. David, over to you, and we're glad to have you back online. What are some successes, challenges, and lessons you've learned in sickle cell advocacy? And what are some other things you've personally done to increase awareness and advocate for sickle cell disease?
Sorry, what was the question?
What have been some efforts that you have engaged in to increase awareness and advocacy for sickle cell disease?
Oh, okay. Basically, before I started speaking out about sickle cell, I wanted to be sure, is this what I wanted to do? And I asked myself, where are the gaps existing in terms of sickle cell disorder awareness and then the care for sickle cell? And I observed that one of the problems is that sickle cell warriors don't speak out about the experience. There is a scarcity of information about what sickle cell is. And then there is always this conflict with care providers whereby they don't understand what you're going through. So how am I going to bridge that gap? And so I decided to share my experience, sharing my experience of different sickle cell crises and complications to be able to make people understand what sickle cell is about, to help people improve care, so that because once the caregiver knows what we're going through and now we are going through what we're going through, they'll be able to give appropriate care, and then to encourage more research into sickle cell disorder. So I started using my experience, and then I had to sit down and ask myself, if I have to speak out about my experience, am I really ready for it? Because I have to talk about my experience with chronic leg ulcer. I have to talk about my experience with priapism. Priapism is that kind of experience that deals with your private life. Are you really interested in making it public? And I asked myself, I'm going to do this. Am I sure I'm ready for it? So I decided, okay, one of the things I'm going to do is use my experience. And I share my experience about sickle cell to other sickle cell warriors and caregivers, and I've seen responses. I remember when I shared my experience about PICA, and I had response from a lot of sickle cell warriors saying that, this thing is called PICA. Also, this thing is because of sickle cell disorder. Most people don't even realize that PICA is one of the problems sickle cell warriors go through. Or even when I share my experience about enuresis, bedwetting, I stopped bedwetting until after 10 years. And I had parents of sickle cell warriors saying that, if I had known, I would not have scolded my child. I didn't know this is related to sickle cell disorder. So sharing those experiences made me give people a better understanding of what sickle cell disorder is about. If you're a caregiver, if you're a parent, if you're a sibling, if you're a family member to a sickle cell warrior, and you see them showing for these experiences, crises, complications, how do you manage it? One of the problems is that they don't even know that some of these things are associated with sickle cell disorder. So when you know that they are associated with sickle cell disorder, it will help you devise an appropriate mechanism to be able to manage them. And then this was able to generate positive response from caregivers, parents, and even sickle cell warriors to also speak out about their experiences, to be able to share their experience with other people. I remember when I published my book, somebody with sickle cell trait spoke to me that she was having crisis. And all through my medical school career experience and as sickle cell warrior, I never got to know that sickle cell carriers could also have sickle cell crisis, sickle cell complications like this sickle cell, people with sickle cell anemia. And so the person reached out to me that everything I described in my book are those things she goes through. And she's a sickle cell carrier. And I said, it can't be possible that she should go back to the hospital. She said she's a sickle cell carrier, she has done tests, she lives in the UK. And I said, well, if that is what you're experiencing, then definitely those are the crises we experience. And that was able to help her approach her caregiver to make them understand that, because she said she has been going to her caregiver frequently and they are saying, no, sickle cell carriers don't have these things, only for sickle cell disorder. Maybe something else is happening. And so we are not giving her appropriate treatment and appropriate attention. So when she was able to use my book and my experience to share with them that these are the things she's going through, she was able to get appropriate response. And then she was able to mobilize other sickle cell carriers that were having sickle cell crisis and experiences that we sickle cell anemic were having, to be able to voice out to care providers and the global community that, hey, sickle cell carriers also have the same problem like sickle cell anemic. And so it is important we approach the care for sickle cell through an holistic manner, whereby we don't only focus on people with hemoglobin SS, hemoglobin SC, we also focus on carriers, we also focus on people who have sickle cell disorder with thalassemia, so that we can be able to reach out to a large community of people who have one relation or the other with sickle cell disorder. So sharing my experience has been able to help me to reach out to more people. And it has been able to help me to give, now I ask myself, what message do I want to give to the world if I'm going to speak about sickle cell disorder? There are people that tell you, there are people that have different messages. Some people make you feel despondent. Some people make you feel there is no more interest in living. There is no point living. But I told myself that's not what kind of message I want to give to the world. I want to make the world understand that sickle cell disorder in my life is not an indication of the absence of God in my life. Secondly, I want the world to understand that there are no limitations in life except for the limits you create in your mind. So even with sickle cell, don't allow yourself to be limited. While I was in medical school, I was involved in a lot of things, and I was also having crisis. My first experience of priapism was when I was in 500 level, and then I was engaged in business. I had 2 business awards. I was engaged in a Christian fellowship. I won an award, and during the period when I was given the award of the best editor-in-chief, our chapter in the country was given the award of the best newsletter in the country. I was engaged in a lot of things. I was also engaged in church. When I was working, I was doing MBA. I was working in Lagos. I was doing MBA in Kwara State, like 4 hours drive distance. And then I was working in a private hospital and also working in an insurance company. I was fully engaged in my church. I was an ESCO. And so I was not limited. And within those periods, I was also having crisis, but I did not allow that to limit me. So my message is to make sickle cell warriors and every other person understand that there are no limitations in life except for the limits you have in your life. Even though you have crisis, even though you have all of these problems, don't allow that to limit you. Then I also want them to understand how to manage it properly. So within my experience, I understood something. You have to be able to identify what works for you as a sickle cell warrior. And it's not only about a sickle cell warrior, but everybody with relation to everything in life. Identify what works for you, understand how it works for you, and then make it work for you. So now for me as a sickle cell warrior, one of the triggers of sickle cell crisis is dehydration. So to manage dehydration, you are requested or you are required to drink a lot of fluid. But personally, I don't like drinking water alone, but I like drinking juice or anything that is sweet. So what I do is I mix equal volume of water with equal volume of juice, and then I take it. So I identify that, to be able to manage dehydration, this is the therapy, this is the approach. And so I make it work for me. So for other sickle cell warriors, I share with them, identify what works for you, understand how it works for you, and then make it work for you. So my advocacy has been focused more on how I can use my experience to change people's perspective about sickle cell disorder. I won't lie about it. I remember I have written about some poems and somebody read about it and said, oh, you don't have to paint it this bad. And I told myself, but that is how it is. I had to share how sickle cell pain is like and comparing it to the pain of labor, when a woman is in labor pain, comparing it to somebody who have a fracture, and also comparing it with somebody that have asthma, having an asthmatic attack, when you are gasping for breath. Now, when you're having sickle cell pain crisis, you also feel that. And the person was like, why do you have to say it like that? I said, because that is how it is. But I'm not going to leave you in the loop of despondency. I'm going to make you understand that even with this condition, don't be limited. God can pull you out through it. So sharing my experience has been able to help me reach out to many people, to be able to speak out about what they experience, and then to be able to seek appropriate care and then inform their caregivers that this is what they go through, this is how it is with sickle cell disorder, and then their caregivers have been propelled to also read further about what sickle cell is and then give them appropriate care to be able to manage sickle cell disorder.
Thank you, Dr. David, for the insight.
Thank you.
Thank you for your contribution in creating awareness and letting everyone know that with the sickle cell, you can attain great potentials. Thank you so much. So rapidly, we are going to go on some of our audience questions. So the first question from Aisha who says, how frequently do sickle cell patients experience crisis? She want to know how frequently do sickle cell patients experience a crisis and then the different level of severity. The reason I'm asking is that I know a couple of people who suffer from this, but one of them could go months without crisis while the other person suffer crisis more often.
Can I answer the question?
Yeah, okay.
It just depends, actually. It depends. It depends on a whole lot of factors. And it actually depends on individuals. Some people can go years without having crisis. I know I'm going to actually use my experience as an example. While growing up, for the first 5 years of my life, my parents already had a child with sickle cell disease who was always having crisis all the time. So when they saw me, they suspected that, when I came, they suspected that it looks like, but then I didn't have crisis. So it was kind of like, oh, okay, maybe not. And you know how so it kind of put like a doubt in them. So when they did my first genotype was at the age of 8. So for the first 5 years, this is different from Sickle Cell Anemia Control Act in the United States when everybody's tested. So in Nigeria, not everybody's tested. So but they were guessing because they already had a child. So by the first 5 years of my life, I didn't have any crisis. And this is because I probably had a high level of fetal hemoglobin. So which is one of the factors that can make some people go a long time without having crisis. Because some people can actually have fetal hemoglobin in their blood up until fetal hemoglobin is baby hemoglobin in their blood up until they are 19, and they might not even have crisis at all. So I didn't have crisis until 5, and my first genotype testing was at 8, and they said I was at 5, yeah, under 4, and then they said that I was AA. Actually, they didn't even. I was misdiagnosed. So, but then, so it was confusing to my parents, saying that, oh, she's having crisis, and it looks like the first one. It looks like the other daughter. So what's going on? How could she be AA and she's having crisis? So I wasn't having that much crisis until 8 when I started having a lot, because then you're playing more, you want to play with your friends, you want to swim, you want to get into cold water, all that stuff. So afterwards, I think as you grow, you begin to know what you can handle and what you cannot handle. So I see that children actually have more crisis because they probably don't know when to stop. So that actually might make some people have more crisis. So these are factors. Maybe more fetal hemoglobin, might be. And some people also have a higher, because every sickle cell disease patient kind of have maybe 1%, 0.5% of A hemoglobin. So people might have more, so which can actually help them not to have a lot of crisis. There became a time that I actually was having crisis every month. So it was stopping me. So because I would go to the hospital every month, and the next month hospital, next month hospital. So and then there was a time that there were times that I had like breaks, like 2-3 years, like, oh wow, I haven't had crisis in a long time. So it actually depends on the person. But when I started taking hydroxyurea, it increased the rate of hydroxyurea worked for me. So it increased the rate of the amount of fetal hemoglobin. So with that, the crisis stopped. It started like once a year, then once in 2 years, then afterwards like once in 3 years, once in 4 years. So it just depends on the person, the amount of fetal hemoglobin, the amount of stress the person go through, and when the person knows when to stop. And like Dr. Owoeye was saying something about knowing your body, like there's actually one premonition that comes like, I might have a crisis. Once you have that premonition, take care of it right away. I take pain medication once I feel it looks like I feel like I might have a crisis. Take it right away. Don't postpone it. Don't say, oh, I'm gonna take the pain medication tomorrow or something. It might be too late.
Thank you, Funke, for highlighting from your experience the different triggering factors. So I want to ask Dr. Melinda or Dr. David, can you have more insight on that?
No, yeah. What I've seen is exactly what Funke is explaining. It's just, it really depends on the patient, and it depends on like lifestyle, and then also sickle cell type, because it's not all, there are different like genetic makeups for different sickle cell diagnosis. And also the body's response to hydroxyurea, because there's some that can have what we would consider to be a more minor form of sickle cell, but their pain is more severe and is more frequent. And then there's some that have a more, what we would consider to be the more severe form of sickle cell, but they're not having as much pain, and they may not even be on hydroxyurea. And so that's why it's so important to go back with the knowledgeable providers, so that they can tailor treatments to the patients, so that they can prevent the pain. And I think something I wanted to share when it comes to the pain is that behind the pain is actually a bigger issue that really places a lot of sickle cell patients at risk of early mortality, would be like the damage that's being done to the organs because of the sickle cells, or called vasal occlusion, or the lack of oxygen that the different organs are getting because of it manifests itself as a pain crisis, but there's damage that's being done behind that. So when we see patients that have a lot of pain crisis, we see, okay, this is a more severe type, and there could be it could be a major, it could have a major health or impact their health in a major way sooner if we're not able to get that under control. But either way it goes, like it really varies. It's not you can't say like you can't really say this is what we expect to see, which is why it gives a disservice to label sickle cell patients as high utilizers, because it just depends on what they need, and we don't want them to not come seek out care if they're experiencing pain, and we haven't found a way to erase pain altogether. So we need to be more flexible and work with just kind of each individual, as opposed to saying this is what should happen and what shouldn't happen.
Wow, I'm just my mind is just blown by you all sharing your experiences and the anecdotes. I know we're past the hour at this point, but I just wanted to highlight a comment that we received from Dr. Bukola Orolu, who is a hematologist with the Lagos State government in Nigeria. And she said, the Lagos State government recently started newborn screening for sickle cell disease in many general hospitals. And I believe this is a welcome initiative, because screening from birth is highly important to identify, like you all said, the different possible genetic variations and traits so that you can start treatment early. And I really like that you mentioned, Dr. Rushing, that it's not just about the pain crisis. The pain is a symptom of what is happening in the body, and then the the multi-organ damage that is going to happen due to that chronic crisis. So I think providers, advocates, policymakers need to understand that it's beyond the pain. There's damage that is happening to the body, and then that has to be mitigated. Just before we round up, I just want to ask you all quickly, just share one quick sentence. The theme for this year's World Sickle Cell Disease is shining the light on sickle cell disease. So one quick sentence, and we'll start with you, David. How would you encourage governments, institutions, and individuals to shine the light on sickle cell disease? Or how would you shine the light on sickle cell disease?
Okay, shine the light on sickle cell disease. Use your sickle cell stories, sickle cell experiences, sickle cell data, sickle cell research to shine the light on sickle cell disease so that people can be aware. The more aware people are, the better we can approach it properly.
Thank you, Dr. Owoeye. Funke?
Yeah, today I'm shining my light on hope. I just want to say sickle cell is not a death sentence. So if you have a child or someone with sickle cell disease, shining the light of hope, the story of hope, there's hope. You can live with it. You can survive. You can live long. It's not a death sentence. And you can also achieve what you set your mind to achieve. So I'm shining the light today on hope.
Thank you, Funke. Dr. Rushing?
How I want to shine light is by saying, set aside for all industries, set aside the stigma, see sickle cell patients as humans, and join like the fight to get rid of this disease and to make life a whole lot better for our patients.
Once again, thank you all for your time. Thank you for joining us on this very special event, World Sickle Cell Day, as we shine the light on sickle cell disease. To our audience, we thank you for your engagement. We thank you for your patience, because we know we're over the hour now. For you all, you are doing amazing work in research, in advocacy, in treatment and care. So what are your social media handles that our audience can use to reach out to you if they have any questions or want to connect with you all about your work? Starting with you in the reverse order, Dr. Rushing, then Funke, then David. Please share your social media handles and how people can connect with you.
Okay, the best way to connect with me is through LinkedIn, and then you would just use my name, Melinda Rushing, on there, and you could just send me like a connection request, and then like or a message. Either way, that's the best way to get a hold of me.
I'm on Instagram, I'm on LinkedIn, I'm on Facebook, so people can connect me through any of these medium. I'll try and send it through this platform so that people can connect with me. Instagram, Twitter, Facebook, and LinkedIn.
I would say I'm basically very old school. You can connect me on LinkedIn, but the fastest way to get me is actually email. So info@childhealth.com, or yeah, you can also connect with me on LinkedIn too.
Thank you both so much. And we would also be sharing links to Shout Global Health, your initiative, Funke, and then also to your book. Please, for our audience, feel free to reach out to them directly. Google Shout Global Health, check David's group book, Life with Sickle Cell Anemia, on Amazon Books and Okada Books, I guess. And please continue in your own sphere to advocate for sickle cell disease, increase awareness in sickle cell issues and the disorder itself. And for us in public health in real life, we hope to continue to shed light on global health issues, to inspire the next generation of providers, and then to celebrate unsung heroes like David, Funke, and Melinda Rushing. So please feel free to like and subscribe to our channel, and we hope to see you some other time. Thank you all. Be safe and be well. Bye.